Okay, so um, I think it's more than 7:10 and we should start. So welcome all. Hello, welcome, Jevin. I'm so happy that this talk is finally happening. We have been planning this for a long time, and I'm very happy and excited to welcome you all to this lecture series. This is the first lecture in the lecture series that an economist is going to organize on different topics under health and healthcare in India. And unfortunately, during the pandemic, the importance of to keep talking about healthcare, to keep public discussion around it has been exposed, and it has also exposed to us that how marginalized communities have been again at they have had to go through multiple layers of exploitation because of the broken healthcare system that we have in India, and and it doesn't only affect access to healthcare, but having a weak healthcare system in place also affects a lot of the how well they do on a lot of health related indicators. And I think most of us are aware that how well India is doing, has been doing economically, is not is in that particular frame. India is one of the lowest spending country when it comes to the percent of GDP that is spending on the healthcare. And unfortunately, that's not the only disadvantage that health sector in India goes through. Along with low state expenditure, healthcare in India also suffers from almost missing public discourse around health related conversation, and missing lens to look at how marginalization, how different identities plays out when you want to look at access to healthcare or health related indicators. So through this discussion series, we are trying to bring focus to some of these points, um, so that after the like I can't say for sure that pandemic is over. So while we are at a little peace right now, we should keep talking about it, and the public discourse should continue. Um, However, when I say that the public discussion discourse is missing, that does not mean that there haven't been people who have continuously talked about it. There have been economists who have been raising questions about how the government should be spending more when it comes to healthcare, health sector in India, or there have been public health activists, scholars, researchers who have continuously talked about the importance of public healthcare and the need to strengthen public healthcare system in India. But in the same breath, I mean, after accepting, acknowledging the work that they have done so far, I would also like to bring to focus that a lot of this discourse that has been present in India when it comes to health has been cast blind in their approach to looking at these questions. And that is why today's session is very special, because Sylvia has been talking about how caste plays out in different forms of in accessing healthcare, and also when you look at different health related indicators. And caste and different identities, how important it becomes, can be guessed from the fact that if something goes wrong in accessing healthcare, or if health sector is affected by the biases that marginalized community go through every day, the end result of this could be very, like, it could result in their death. And something that we are going to discuss in coming sessions also, that the caste blindness approach that people have taken so far whenever they talked about health has led to a lot of these things that should have been avoided. For example, there is one paper that we are going to discuss in coming session, where we look at how Dalit Adivasis have lower life expectancies compared to upper caste in India, and there are so many other topics that we should be looking at. So while acknowledging that India is generally suffering from how important, like how they're supposed to take health very importantly, but it has been missing from states' priority list and also public discourse. But even when the people who have talked about public health in mainstream, they have mostly taken caste line approach, which has had harmful effects. And I will not take a lot of time because we have to learn a lot from Sylvia's session. But I just wanted to say that in the series, the lecture series, we are not going to look at only certain aspects when it comes to health and healthcare. And when I say these two words separately, health and healthcare, so I just wanted to make it very clear that when it comes to healthcare, there are different things that we should be looking at. One, how the role of frontline worker, and what is the treatment they are being given to. they are overworked and underpaid, and how important they become in improving the accessibility to healthcare. Or we should look at sanitation workers, the workers who are responsible for ensuring that the hospital, the healthcare that you're going is in that condition that one is able to access it. But the role that caste plays in the cleanliness, and how the concept of casteist notion of purity in pollution is very prevalent when we look at sanitation work in healthcare also. Or when we look at other medical staff like nurses and doctors, we look at on what factors their services depend. Or we look at how the medical education, the caste bias in medical education affects that who finally gets the education and who finally gets to provide these services, and how that ultimately determines that what sort of healthcare is accessible to people. That's one aspect of it. The second aspect of it would be that how access to healthcare has affected different health-related indicators, or generally how different communities perform on different health-related indicators. For example, what is the life expectancy, or what is the nutritional status, what percent of children from certain community have stunted children, or how much state is spending in improving the physical infrastructure of hospitals. So these are different questions. Some of these questions have received a lot of attention in the past, and some of these questions which has a lot to do with how caste plays out, how identities plays out in accessing or in delivering services of healthcare has not received that much attention. So through this lecture series, we are trying to bring focus back to health-related discourse, but we are also trying to bring to mainstream the role that different identities can play out, and how important it is to not be caste blind, not be identity blind when we are talking about policies or health-related indicators. Um, so thank you, Sylvia, for agreeing to do this session with us. I have personally learned so much from your work, and I'm very happy that this series is starting with your lecture. So I'll hand it over to Suresh and you now, and looking forward to the session. Also, sorry, before I hand it over, the session is in a way that Sylvia will talk for some time, and then we will have interactive sessions. So if you have questions throughout while she's speaking, or if you have any other question, please feel free to type in the chat box. Okay, Suresh.
Yeah, thank you, Aditi. So it's given me immense pleasure to introduce Dr. Dr. Salvia Karpagamam. So actually, I just want to tell something before introducing. So as a Bahujan economist, as a part of lecture series on caste, class, and politics, health in India, come up with the different aspects of caste and health in India with diverse and expert speakers from different fields, including a grassroots level workers and like ASHA to a policy advisors. So as a part of this series, today we have our first session on nutrition, caste, and policy with Dr. Selva Karpagamam, ma'am. So she did MBBS and MD in community medicines, and she is a public health doctor with around 18 years of experience. She has worked on health social determinants from a rights perspective with communities, networks, as well as human rights organizations such as Amnesty International, People Union for Civil Liberties, People Health Movement, World Health Organization, etc. She has been involved in the COVID-19 related public health and relief work. She is currently working on creating a draft public health policy document for healthcare for the state of Karnataka. As a part of Right to Health campaign at the state and national level, she has conducted many trainings, had many research, and published more articles on this. And she has conducted mainly like qualitative research on the impact, particularly on the vulnerable communities. Basically, she's talking about like privatization and commercialization of healthcare and nutrition, and how it impact on the caste and different vulnerabilities. She has published in peer-reviewed journals and about the impact of public-private partnerships and health, public-private partnerships and health insurance, as well as critique the lack of regulations of the private healthcare. So as a part of larger campaign on right to food, she has participated in fact-finding visits, trainings, advocacy challenges, and centralized and corporate-driven schools, school lunch program, denial of X, ideological imposition through the government food schemes, etc. So today she will be focusing mainly on how the caste and health are related, and how it impact on the, what are these health indicators on the different caste groups, basically vulnerable groups. So we know that caste play an important role in every aspect, from socio-political and whatever you take. So I don't want to take much time. So just I'm giving this floor to ma'am so that she will have many things to say. So ma'am, now floor is yours. So you will be having around 25 to 30 minutes, ma'am. And after that, we will have a discussion. Hello, ma'am.
Yes, Suresh. Yes. Thank you. First of all, I would really like to appreciate the Bahujan economists for doing this series. I think it's really important that these conversations have to be had. And especially if you look at nutrition, it's always been an expert domain. It's, people who mainly from dominant caste groups who have, they've identified, self-identified and also by others as experts. And they have, for several years held the sway on deciding what is good nutrition and, what should be given to people, what people should eat. Also, what is bad food, what is food that should be criminalized and targeted. So I think moving this discussion on nutrition away from the so-called experts into people who actually have a lot of knowledge about food, especially if you look at the traditional knowledge systems, marginalized communities, the kind of knowledge that they possess about food, it's actually very incredible. And I think having these kind of conversations and especially foregrounding how caste plays a crucial role in nutrition, I think it's very important and much appreciated to the group for doing this. So I would, the topic is actually quite broad, and there's lots that one can say about caste and nutrition. So I thought I would specifically talk about anemia, because anemia, first of all, it's a very serious public health problem, and it's also very closely related to both caste and generally nutrition. So if you, for example, in India, it is a public health concern, the kind of anemia that is there. So it will not be in isolation. So you'll not have such high levels of anemia without other nutritional deficiencies. So it kind of throws a spotlight on the overall situation of nutrition in the country. And I want to just give some statistics because it's important for us to understand the scale of the problem. And Suresh will also share some of those screenshots, mainly from two sources of data. One is the National Family Health Survey, that is the 5th round. And we also have the Comprehensive National Nutrition Survey. And both of these are the most recent data that we have on nutrition. So just looking at children aged 6 to 59 months, that is children less than 6 years, even at the age of 6 to 8 months, the children, 75% of the children have anemia. So it could be, mild or moderate or severe, but the total percentage of anemia is 75%, which is a huge number. And both males and females have equal prevalence of anemia, which is something for us to recognize because very often of course, the girl children and women tend to lose more blood because of menstruation and because of pregnancy, but it doesn't mean that the men are well nourished. The malnutrition is also equally prevalent among the males, whether it's the younger boys or whether it's the older men. And the anemia levels increase with the birth order. So if someone is a first child, it's about 66%. And if it's a 4th or 5th child, then the prevalence of anemia goes up. It's almost 71%. And if a mother is schooled, that is the longer years that a mother has schooling, there's less likely that the child is to have anemia. So if a mother doesn't have schooling, then the 71% of those children are likely to have anemia, Whereas if she has about 12 or more years of schooling, then it is about 62.5%. This is an important point because with data like this, so data, speaks to us, and it's important that we look at data, but it also has huge scope for misinterpretation and abuse. And what happens usually is people then start blaming the mothers. They'll say, oh, she's uneducated, that's why her child is malnourished. Or these women, they don't care about the children, they're uneducated, they don't bother about their own health, they don't bother about their children's health. But this data is important for us to understand that low education also comes with other vulnerabilities. So if a woman is, she's not had schooling, it's possible that she's also from a Dalit or Adivasi community, that she didn't have school facilities, that she was discriminated at school and therefore dropped out earlier, or that, the school was too far away from her. So there are multiple reasons why, women have not accessed education, and that is also associated with the kind of anemia that occurs in the communities. So, women who haven't had that much education, who might also be Dalit and Adivasi, might also have to, they may also face exploitation at work. There may be labor law violations that they face. They may have low wages for the same amount of work. And all of these, I think many of us would know that there is definitely, caste, gender, and now increasingly religious prejudices which operate in these instances. And Christian children have the least anemia of 53%. So we'll have to, analyze it and try to understand why these things are happening, and things together and see why certain communities are more at risk and why certain communities seem to be protected. So again, children from scheduled caste communities have an anemia of 69.5%. Tribal community children is 65.2%, and in others it is 65.8%. So it's more in children from tribal communities. If the child lives with both parents, the child's life, it is 76%. So again, if you look at migrant communities, if you look at communities where there's where they have precarious livelihoods and little access to incomes, and those communities which migrate, then the risk for those children is much more of developing nutritional deficiencies. Again, if the mother is not anemic, the risk of child having anemia is 60%. If the mother is severely anemic, then the risk in the child is 77%. So we can see again that nutritional deficiency have an intergenerational effect. So a mother who is less educated, who's less nourished, is more likely to have a child with anemia. And it's 62.6% in the highest wealth quintile and 71.5% in the lowest wealth quintile. So of course, the income plays a role in one's nutritional outcomes. And there are some states, I'll just mention those, Chandigarh, Himachal Pradesh, Manipur, Meghalaya, Mizoram, Nagaland, Goa, Andaman and Nicobar Islands, and Lakshadweep, which have the lower levels of anemia. You also have, sorry, did you put the, I can you not put it on the screen because I lost my document. Can you share it on chat? Okay, thanks. Okay, yeah, and it's the lowest in Kerala at about 39%. Also, as per this CNNS data, only 9% of children aged 6 to 23 months receive iron-rich foods. The mother's diet influences the consumption of iron-rich foods by the children. And in 7 out of 30 states, less than 5% of children 6 to 23 months consumed iron-rich foods. And again, from the CNNS, stunting, that is less height than expected for age, is about 39% in the scheduled caste and scheduled tribe children, and underweight, that is less weight for age, is about 40%, the SC and ST children, whereas in other category, it is around 32 to 33%. And like I said, with such high levels of anemia, it is unlikely for other deficiencies not to be there. So along with anemia, we also have high levels of vitamin A deficiency, vitamin D deficiency, zinc deficiency, B12 deficiency, folate deficiency, and overall there is, protein deficiency. Overall, there is stunting and there is undernutrition among a majority of the Indian population. Now, if you look at anemia and what is the effect of it, it has serious effects. So if you look at children, a child who is anemic has multiple barriers to having a good quality of life. So first of all, the child is, like I said, he or she may not reach their expected heights and weights. You're also very likely to have other nutritional deficiencies. Therefore, they are more vulnerable to other infections. So if you look at in a year, the frequency of infection in an anemic child is much more than in a child who's otherwise nutritionally healthy. More frequent diarrhea attacks, more frequent respiratory infections. And therefore, because of that, the child becomes more malnourished, and therefore the child gets into a vicious cycle, which very often the child cannot come out of. And you have high mortality also, so high death rates in many of these children. But apart from dying, a lot of children actually have like very poor quality of life. So if, for example, if they go to school, they may be labeled very soon as slow learners. They may not be able to concentrate in school. They may be drowsy, their attention span is limited. In fact, many of the children who have anemia may also have other kind of cognitive or psychomotor disorders, neurological disorders. And if you look at it from a caste angle, then you can imagine how quickly these children will be labeled as slow learners, stupid, unfit to be educated, or their chances of dropping out is more, and the chances of going into child labor, the chances of being bullied, harassed, all of those things, they come together, they are associated with all of this. And and definitely anemia is one of the biggest contributors to maternal deaths in the country. So it's a preventable nutritional cause of maternal mortality in India, and it is the largest preventable cause. Again, apart from deaths, the women can have, bad pregnancy outcomes. The child can be small for date. So, we have an expected weight for the child for a certain, duration of pregnancy, but the child may be small for that expected date. Women, even if they are not pregnant, they can have chronic fatigue. So they're always complaining of tiredness. They have joint pains, they have body aches. So basically the quality of life is, it's really bad. So imagine if you as a person, you want to do certain things in life, you want to, achieve certain things, you have some dreams, you have certain aspirations, but your body is not allowing you to. Basically, you're constantly tired, you're constantly feeling sleepy, and you're not able to do all the things that you actually, your body wants to do. So, and that is actually one of the very common symptoms of anemia, and very poorly diagnosed. So a lot of women actually go to the hospitals complaining of these very vague symptoms. They say we have body ache, we're tired. Sustu, they say that it's a very common word in, in Karnataka. And the health system is so poorly prepared to identify it, and they don't even do basic blood tests, and they diagnose a person as psychosomatic. They might say, in fact, doctors have a name for it. They call it in Karnataka, they say Mai Kaikal Sustu. They say, MKKS syndrome. It's a way of mocking the patient and saying or it's, it's the usual women coming and complaining as usual, and they just give her painkillers and send her home. So again, like I said, quality of life is affected. They're more likely to have premature deaths. If they're pregnant, the baby is more likely to die, more likely to have smaller babies. The women are more likely to have complications. Severe anemia over a period of time can lead to heart disease. And that is like the clinical part of it. But I think we can, like, I did mention it, the other consequences, in terms of wages, in terms of the number of days that people can work, in the number of the kind of jobs that people can take, how much they're able to achieve in their lives, all of those get affected with this kind of nutritional problem. And some things, I think it's important to understand, because there are a lot of misconceptions, especially about anemia, even among doctors. So if they do actually diagnose someone with anemia, then the treatment, they'll tell her, eat vegetables and take iron tablets. And that is standard. And I think most of us know that. And most of doctors also think the solution to any problem is stop eating meat. So they do it like a standard thing. It's like, stop eating meat, take vegetables and fruits, and take iron tablets. But that is not something, that's taught in medical school. That's not what is there in the textbooks. According to science, if you look at nutritional science, especially with anemia, it's like iron is only one component that is required to manage anemia or to prevent anemia. So you need good quality hemoglobin if you don't want to get anemia. And for hemoglobin, you need multiple nutrients. You need different kinds of vitamins. You need different kind of minerals. You need good quality proteins. And the best sources are red meats. This is what we've learned. It's not something I'm saying because, I have some hidden agenda. There is two kinds of, it comes from animal sources, but it's better absorbed, it's better quality. The body is better able to use it. You have the non-heme iron, which come from plant sources, which are not as well absorbed. It's not as well utilized by the body. And many of the plants have other components, like, for example, they might have phytates or tannins or polyphenols, which prevent the absorption even of the iron that is there in the plants. And in fact, the presence of heme iron is basically from, animal source foods. It actually increases the absorption of iron from plant source foods. So if you're having, a plant-based meal, and to that you add some heme iron source food that is mainly from animal sources, the absorption from the plant-based food also increases, along with vitamin C. So vitamin C is very important for the absorption of iron from food. And very often, plant-based foods, even if they do contain iron, which is not the best quality iron, it's definitely less poorer quality than animal source food iron. Even those can be, the absorption can be affected by a whole lot of things. So, for example, if you're consuming milk, tea, coffee along with your meal, then the absorption of iron from your plant-based food can come down. So and also, like I said, there are many phenols and tannins which prevent the absorption of iron. Now, since and what we've been taught is that the best sources of iron are red meats. So any meat that like poultry, chicken, and fish do have some amount of iron. Eggs also do have some amount of iron. Milk also has some amount of iron. But the best sources are red meats. And the organ meats, among the red meats, the organ meats are the most superior source of not just iron, but different nutrients. And like for example, if you need protein, the best source of protein can come from beef. So if you take, say, 100 grams of beef, then almost 26 to 27% of the daily requirements of good quality protein can come from 100 grams of beef. And similarly, you get most of your essential amino acids. So we have like 9 essential amino acids. All of them can come from beef, apart from, say, calcium, riboflavin, and many of the other nutrients. So it's a very nutrient dense food. So that is what the science says. But if you look at actual policies, if you look at actual interventions, then there is a whole lot of, first of all, there are a lot of misconceptions. People have a very poor understanding of protein. So for example, they might tell you that soya has protein, beef has protein, so why don't you eat soya? And why are you making such a fuss about beef? But again, in terms of quality, it's very different. Most of the protein of soya is not available. And apart from that, it's not digestible. So you never take soya from the plant and just eat it directly. It needs to go through a whole lot of processing because it's very difficult to digest. Apart from that, it also affects your thyroid. It can increase the estrogen levels. A large amount of soya can cause, male gynecomastia, that is male boobs. Basically, it can, increase the estrogen levels. It can cause abnormal deposition of fat. So those arguments are not based on science. It's not possible to compare, say, beef liver with soya. They in terms of quality, they're completely different. And beef is, completely superior in terms of bioavailability, in terms of digestibility, in terms of quality. So I think that's one misconception. And the other thing is that this whole idea that India is a vegetarian country, it's somehow, so important, especially for people outside the country, to project India as a vegetarian country, land of, honey, yoga, and vegetarianism, and mysticism, and all those things. But actually, the fact of the matter is it's only 20% of people who self-identify as vegetarians, and the rest are actually people who, given an opportunity, would consume meat. And a lot of them actually are not able to consume meat as often as they want. And that, I think, the caste angle, it's easy to understand how the caste angle plays a role there, and we can also discuss it a little more. There's also, so a lot of traditional communities actually eat a lot of these foods, which are rich, nutrient-dense, animal source foods. Like, for example, almost 18 million Indians consume beef. People from the Northeast, people from, Dalit communities, Adivasi communities, Christian, Muslim communities. And it's a cheap source. And it's very interesting. Like, if you want to do a sociological study, you should just go and stand outside a beef shop. You will understand, that different parts of the beef is available to people based on how much they can afford. So if you're really well off and you can order online and you want it to be discreet, you'll get your beef delivered to your home. But there's also people, who want to buy, say, boneless beef, who are ready to spend a little more money. But there are people who may not have a lot of money, who might come and say, give me 50 rupees of liver, or 50 rupees of spleen, or, the cheaper parts, which are again very nutrient dense. So the nutritional science is very sound in a lot of these communities. If you talk to the grandmothers, if you talk to the, older women in the village, or, even in the cities, they have an understanding of what is good nutrition. And bringing, say, organ meats into the diet, or bringing in some amount of red meat into the diets, is actually a nutritional science. It is nutritionally sound science. And these are getting criminalized. And we all know the kind of language that is used People say this person was caught smuggling beef, this person was lynched, this person was, there's a cattle trade, mafia. So what is normal is actually being converted into a crime, and it's being made illegal. People are being targeted, people are being attacked. And all of this, I think we have to start looking from a caste lens, because there is no science to it. There is no basis to bring in the cattle slaughter bans that are being brought across the country. In fact, it is, it does make economic sense, it does make nutritional sense, and people have lost their livelihoods overnight because of these cattle slaughter bans without any alternative. And people have lost a source of nutrition. So it's only caste which has come in such an instance and taken away and criminalizing what people have been traditionally eating. So when you talk about malnutrition, and when you say that Dalit children are more malnourished or Adivasi children are more malnourished, then we also need to looking at why. And we should stop blaming the communities, and we should stop saying that the communities, they don't have the knowledge, they don't want to feed their children. They do want to, they know what to feed their children. It's you who's coming in, bringing all these laws and policies, which are preventing people from eating it, criminalizing it. In fact, in surveys, people are so hesitant and so scared to say that, we like beef. In fact, children, when they don't want to take the foods that's eaten at home to their schools, because there's so much of harassment and so much of discrimination that they face, such verbal abuse almost that they face for the kinds of food that they eat at home. Children have told us that our teachers say you should be sensitive to the other children. Therefore, don't bring foods that make other children feel unhappy or other children feel disgusted. Or they also told by teachers and faculty that if you want to be clever, if you want to do well in life, you should eat vegetarian food. Your body might develop if you eat meat, but your brains won't develop, which is again nonsense, because the brain needs animal source food. The brain, in fact, requires fats, it requires proteins, it requires so many nutrients, and without that, the child's brain cannot develop to its full capacity. So definitely in terms of the cattle slaughter bans, there is absolutely no rationale for it, but it's being implemented. And we all know about the Gaurakshaks. They go in mobs, and they attack people. They're given legitimacy by the state. They're given, they're almost seen as a foot soldiers of illegal law. It's a law that is bad, and then you have people actually implementing a bad law. And apart from that, I think it's well known about the targeting of people who eat beef. There is also targeting of egg right now, which I think many of you may be aware of. There's a lot of actually articles that have come out on it. The denial of eggs in the midday meal schemes, and the reasons being given are mainly ideological. They say that it affects the sensibilities, the very fragile sensibilities of the people who don't eat eggs, who most often don't even study the government schools. So denial of eggs in the midday meals, and it's not only denial, it's also criminalization of eggs that is happening. And recently there's been this whole issue about halal and jhatka, where they're saying you should boycott halal meat and you should have jhatka meat. But there are no jhatka shops. There are hardly any jhatka shops. And we need to also look at that. Why are there no jhatka shops? What is a caste association of meat? Why is this meat industry, why hasn't it developed? Why has there not been enough investment? Why are only certain communities handling meat? So all of those, questions need to be asked. And unless we start looking at these start using caste as a framework to look at some of these nutritional deficiencies, we are only going to go along with the same narrative. We are going to say, okay, eat your fruits and vegetables, eat your iron tablets. And of late now, the government is talking about fortification. So basically, they're saying, okay, we have such high levels of iron deficiency, so we'll add iron to your cereals. So basically, the kind of vegetarianism that the rich eat and the kind of vegetarianism in terms of policy that are pushed on the poor is very different. It's what we say is a cheap vegetarianism, because it has only cereals and sometimes millets, but it doesn't have any of the other food groups. And so what they're saying is, we'll give you cereals as part of your PDS or your midday meals or your ICTS. And because you're getting a nutrition deficiency for eating such, nutrient poor foods, therefore we'll add iron to it. And tomorrow they'll find, some other deficiency. They'll say, okay, then we'll add calcium to it. Okay, then we'll add, I don't know, vitamin A. So they keep adding nutrients, and that's where the corporates come in. So the corporates have a huge role to play. They're always waiting to intervene in terms of nutrition policies, and fortification is one aspect of that. But studies show that fortification doesn't really help, especially in a country like India, which has multiple nutritional deficiencies. There's no replacement for nutrient-dense foods. So that's just to give a context, and I think it's left for us also to think through how in each of this caste operates, and how, unless we actually address caste, we're not going to ever address the malnutrition in the country. So I'll stop here, and then we can maybe have some questions.
Yes, ma'am. Thank you so much. So you took us into different aspects, like what is the like how this caste impacting the health indicators. Specifically, you have taken anemia, and so you are talking about all those like signs of food versus other caste of food, like how these traditional communities were doing, and vegetarian country with only 20% becoming a maximum majoritarian. So you covered almost like most of the topics, ma'am. So when you are talking about something like the students coming from the marginalized because of this food deficiency, so they say that you are waste fellow, you are stupid, you don't know anything, all those things. So I got one point. Like actually, I studied in a central government residential school. So when I went to after writing exam and then got into merit and I selected there. So in that school, like in the first week only, that one of my ma'am told me that, so you coming from a village, you don't know anything, you are unfit, so better take TC and go. So like that she was telling me, I don't know what basis she told me. So I just got my I remember that point, ma'am. So now we have some questions, ma'am. We will just look into the chart.
Yeah, I saw those questions.
Yeah, but many of the questions you have covered already, ma'am.
Yeah, I mean, some of them, like for example, what Kuldeep is saying, isn't it sad that red meat is not good for health? It's actually not true, because most of the other studies that have been done till now, association studies, they're not causation. So that whole idea that red meats increase the risk for heart disease, cancer, and diabetes has been disproved. There's studies to prove that. In fact, the biggest causes for these diseases, that what we call the non-communicable diseases, are sugar and grains, like basically what we call cereals and millets, trans fats, and junk foods. So if you're having a diet that is balanced, so basically we have 6 food groups. So you have cereals and millets, you have pulses and legumes, you have milk, dairy, and you have the meat and poultry, fish, and you have the fruits and vegetables, and fats and oils. If you have a balanced diet from all of these, then it's very unlikely that you'll get these non-communicable diseases. But if you have a diet that is very rich in cereals, and sugars, trans fats and junk foods, then that is what is going to cause all of these non-communicable diseases. And what Nina is saying, that levels that trigger declaring one is anemic is too conservative. And okay, so this there is a group of researchers who have used the comprehensive National Nutrition Survey data. And basically what they're saying is anemia is not a problem. So why do you want to fortify foods? So basically they're saying your cutoff points are the problem. In fact, what you should do is, like for example, instead of having a cutoff point of say 12, you can have a cutoff point of 10. So that means lesser people are going to have anemia. So it's not going to be a public health problem. And that is a very problematic, and many people have critiqued that approach. So basically what they have done is they've just looked at data, and the data in the CNNS is actually skewed data. It's not represented data. They've taken that and they've done some analysis on it, and they've reached these conclusions. But it's for something like anemia, you have to work with the clinicians. You have to look at the clinical impact. So if I, as a doctor, if I'm seeing a patient and she has a HB of 12, and I say, okay, your hemoglobin is on, say, borderline, and you have to treat. And if she has a HB of 10, and I say, you're having lower levels of anemia, so I'll have to treat you. I'll have to, make sure that, your iron levels improve. If these people's cutoff is being used, then I'm not going to worry even if the patient's HB is 10. I'm going to tell her it's fine. You go home. It's not a problem. And, that can have huge consequences. It can affect the patient's outcomes. It can affect her health. It can affect her maternity outcomes. So it's actually very irresponsible to actually draw cutoffs from that kind of data. So if you want to actually devise a cutoff, what you should do is you should take the healthiest population. You should take, like, not just this generation, at least 2 or 3 generations should have had good nutrition. You take the best in the country, the best population, the most well-nourished, and you draw the average from them. You have to say, okay, in this population, the hemoglobin level is around, say, 12 or 13, and that is what we'll use as a reference for the rest of the country. You don't take people who are already malnourished, take an average and say, okay, that is the new average for the country. So it's a very irresponsible kind of approach, and it has been critiqued.
Sorry, Cynthia, what is the cutoff approach that has been taken by this group that you just mentioned?
So, I mean, I can share some of the material on that. So basically they're saying the cutoff is too high. You need a lower cutoff, and basically they're saying the way of measuring anemia, like you have venous, you can take blood from the veins, or you can take it from the capillaries. So basically they're saying the methodology is a problem, and actually anemia is not such a big problem as the data is showing.
Yeah, yes, ma'am. There is one more question. Do you think that COVID might have increased the nutritional disparity among the caste groups in India? If yes,
sorry, there's Aparna's question also, no? The depletion of traditional sources of nutrients with more fortified and unnatural foods. So I'll just respond to those questions. Yes. Also. Yeah. So basically, it's true, Aparna, what you're saying is true. Like, you can't keep replacing like one nutrient after the other, like taking cereal, adding iron to it, adding, one nutrient to a nutrient per food. Because first of all, we don't have an idea of what are all the nutrients that the human body needs. The only thing we understand is what research has been done till now. And by bringing in this idea of fortified foods, you also, first of all, you're going to increase the cereal consumption. You're not going to have, you're not going to focus on increasing diversity. You're not going to focus on increasing the, people being able to use their traditional foods. So you're going to make them very company dependent. The corporates are going to become indispensable, and it's not actually the solution to nutritional issues in the country. So fortified foods are just what I would call a caste and a corporate nexus. So on the one hand, you have the caste agenda, but then along with that, you also now have the corporate agenda. Amit's question, have genes any role to play in the subpar health of the Bahujans? I think it's the other way around. I think I would suspect that the Bahujans have better genes and their poor health outcomes are possibly only because of the other factors, environmental factors, like what we call the social determinants of health. Like it's well known that if a woman is educated, is more likely that her children are healthier, her children are better educated, all her health outcomes are better. She has better access to contraception, she's better able to make demands in terms of wages, she's able to get better jobs. So therefore, it's the environmental factors, I think, which affect the health of the Bahujan community more than the genes. Okay, do you think COVID has increased the nutritional disparity? Can we say that NFHS is able to reflect upon the same? So I think the NFHS data was collected just at the start of the pandemic. So I think all of us fear that post-pandemic, there will be a huge surge in some of these nutritional deficiencies. And definitely the access of some communities to healthcare was affected. It became very visible during the COVID pandemic. I think what Aditi said also is important. I'll share the link. We actually did a study on the occupational hazards of what we call the invisibilized frontline workers. So of course you have the doctors and to some extent the nurses who are like everyone's clapping and celebrating this community, who are often dominant caste, male, very much in the foreground in terms of the healthcare system. But you also have at the other end of the spectrum, the people who are working with the mortuaries, people working with the bodies, the cleaning staff, the municipality workers who were again exposed to a lot of occupational hazards during the COVID pandemic, but faced a lot of caste-based discrimination because most of them are from Dalit communities. So if you look at the health system itself, even within the healthcare system, there is a lot of disparity and discrimination, but there's also by the healthcare system. So with COVID, this whole idea of Tablighi Jamaat was brought in, which has no scientific basis. In fact, it made us lose crucial time to actually do something scientific and evidence-based. So because of that, there was denial of healthcare and negligence that the Muslim community faced. Pregnant women, there were incidents of pregnant women not being denied access to healthcare only because they were Muslim. So discrimination, I think, is pretty normal by the healthcare system. We also have discrimination of transgender community based on occupation. If someone is working as a manual scavenger, if someone is doing sex work, or if someone, or even apart from occupation, if there's a teenager who needs reproductive health services, or someone who cannot pay, or someone from a rural area who comes to an urban area, or who cannot speak the language, all those discriminations operate by the healthcare system and became very visible during the pandemic. Ideally, I think the government should have even post-pandemic, at least done a survey to see what is the impact, or focus on interventions to address the impact. But of course, they are full-time engaged in anti-minority work. So I don't think they have made the time to address some of these issues.
Yeah. One more question from Shivani.
I also have a question.
Yeah.
Yeah, please, Shivani's question, we can get to that.
Shivani, about the criminalization,
Yes.
Don't say non-vegetarian, say meat-based diets. it's people who eat meat also eat vegetarian food. They also eat vegetables. So why are we saying non-vegetarian? It's a meat-based and not meat-based. There are people who eat meat and vegetables, and there are people who eat only vegetables and not meat. So they're the ones who you should say non for. Okay, sorry. About the criminalization isn't income or direct and plausible explanation. Okay, majority of Indians are now consuming meat-based diet. I would request you to shed some light. Okay, wait. Kuldeep is saying, does having a poor nutrition persist to a genetic level? Okay, so basically, what Shivani is saying, I think if you look at it from the caste lens, then it's not so different. And when you look at meat, see, like a lot of researchers actually get into this issue because in UP there was a study by the IFPRI, and we actually critiqued that study. I'll share that link. So basically, what they said is that women who consume vegetarian food have much more diversity than those who don't. That they said non-vegetarian than the non-vegetarian people who consumed a non-vegetarian diet. But of those who consumed the non-vegetarian diet, only 4% had actually consumed eggs in the previous week. So the issue is not about whether people are meat eaters or not. It's also about how much are they able to actually consume, how much access do they have. And that is, I think, very important when we collect data, because the researchers actually play that game. They don't look at the economic status, they don't look at the social status of the people who are vegetarian, and how even if they don't eat meats, they actually have animal-based food like milk and dairy, ghee, butter. They also have more likely to have nuts, pulses, legumes, and a more diverse kind of diet. And that's because of their social location. Whereas even if someone is a meat eater, because of her social location, she's also less likely to have decent wages, be able to buy the kind of food that she wants to for her family, cook the kind of food that she wants to. If there is a cattle slaughter ban in an entire state, then how are people going to have access to beef? If they're being lynched and people coming into houses and saying this looks like beef and we're going to beat you up or we're going to kill you for this, that's the culture that we need to start looking at. So having these very superficial kind of studies saying vegetarians are better nourished, meat eaters have like the other questions, they are like more likely to have heart disease or more likely to have cancer. We need to stop looking at it from those very superficial kind of lens, and we need to analyze it much more deeply. I think researchers are hugely problematic, and my personal opinion is, if people who are vegetarian shouldn't be actually doing research on nutrition. And Kuldeep's thing, see, poor nutrition and the genetics of it, I think we can only start talking about it after addressing the nutritional issues. So if see there are effects, like so for example, if a woman is badly nourished, then her child can have nutritional deficiencies, and therefore when that child goes on to have another child, the effects can be there, but they're not genetic effects. They're more related to nutrition. And the first thing we have to do is address the nutritional issues, and only then I think we should start talking about the genetic issues. And this, if parents is prone to poor health, it leads to persistent of, yes, definitely, the malnutrition has an intergenerational effect. Women who are less nourished are likely to have babies who are less nourished. Scientifically, is there any substitute for red meats? No, there's no substitute for red meats. So people who don't consume red meats, they can, they can address some of the nutritional deficiencies by having a balanced diet, having foods from multiple food groups. And if people are vegetarian, then increase your consumption of dairy, milk, ghee, butter. So there's again a misconception that if you have high cholesterol, or if you're fat, obese, you're overweight, or if you have heart disease, if you have diabetes or hypertension, you should cut down on fats. But that's not true. A lot of these fats are very important for preventing a lot of these non-communicable diseases, but also for they help in absorption of important nutrients, like vitamins from the body, from the diet. So vitamin A, D, E, and K, even if they're present in the diet, they'll not be absorbed if you don't have fat in your diet. So ghee, butter are actually important fats. You should consume adequate quantities of them, and you can increase your consumption of pulses. So for example, if you're taking say rice and cereals and millets, along with that, the ratio of 3:1. So 3 portions of cereal and millets, 1 portion of pulses and legumes will give you most of the nutrients. It'll balance it out. So what is deficient in one group will be balanced out by the other group. Along with that, if you add ghee, butter, and you add vegetables, you add milk, paneer, milk products, that helps. And along with your meal, it's best to avoid tea and coffee and milk for at least an hour before and after. Increase your consumption of vitamin C rich foods, because all of those will help to maintain your improve the absorption of iron from vegetarian diets.
Yeah. There is one question. Yes.
Yeah, Deepti.
So I actually have a couple of questions. You can answer them separately or together. So first question was that I know you started the session with saying that how anemia is high in both male and female children, right?
Yeah.
So I wanted to understand, does this pattern go away as male children, they grow up and they turn into adult, and the anemia remains high in women, and then that is how is that spread caste wise? And the second question was that you have very nicely summarized the effect of malnutrition on clinical outcomes, and also how that affects quality of living. Let's say clinically we look at how they are performing on certain indicators, but in terms of quality or standard of life, we look at how that affects the learning outcome and how that adds to the discrimination that people from marginal communities are already going through. I was curious as why, I don't know if this question is correct, but in my understanding, these clinical indicators have received a lot more attention compared to how nutrition deficiency affect quality or standard of life that people, especially marginalized communities, lead. So do you think that question is correct? And if it is, why do you think that is the case? And one question which is not related to both of this is about how does community-based norms and practices can play a role in improving the nutritional intake of especially pregnant mothers, because as you have said multiple times that this intergenerational nutritional deficiency is hard to break, and it affects both female and male child, and it goes on for generation after generation. So it's when the woman is pregnant, is that the right time to for us to target our intervention, and what could be the ways to look at these interventions, and what is the effective way to tackle this?
Okay. I mean, as far as I see, the nutritional science and the traditional knowledge of marginalized communities, there is a lot of alignment. So there's a lot of understanding, a lot of awareness. So I think it's the groups that are in the middle, groups that are making decisions, groups that are making policies that are the problem. So I think it's very important to reaffirm the traditional knowledge about food, break a lot of these misconceptions and a lot of the false propaganda that is only based on ideology, which is being propagated by doctors, by researchers, by media, by even civil society, by faculty in schools. You constantly have teachers telling you wrong things about nutrition. Like I do sessions for students in colleges and schools, and they come later and tell me, is it true what you're saying, that animal foods are not bad for us? We are constantly, told that it's bad for our health. And doctors also, give this very wrong advice. So I think it's important to reclaim the knowledge that people have, to affirm that knowledge, to, validate it, and to move this whole discourse of nutrition from this, so-called expert domain, which is not actually expert. It's only ideological domain, and actually, bring it back to what people already know, actually. And also to counter some of these arguments. So right now, like someone, I think Ishika had shared this question about the climate. So again, there's a lot of targeting of especially red meats, saying that it is causing damage to the climate. But this is very much a billionaire corporate-led agenda. So we've actually written a critique about this whole Eat Lancet Commission, which came to India, which said that we are very concerned about the climate, and animal source foods are the biggest contributors, especially red meats are the biggest contributors to climate change. They appreciated India. They said it's very good that you all are mainly vegetarian. It's very good that you all, you all are promoting plant-based foods. But it's it's a lot of untruths there, because we also have high levels of malnutrition. And they were like, it's okay, as long as you're malnourished but you're also concerned about the climate, then we are okay with it, and we want other countries also to be like India in terms of your malnutrition, which is ridiculous. And in fact, if you look at the actual breakup, the biggest contributors to pollution are the industries, it's the automobiles, it's even, the use of digital media, and there's very little talk about that. The people who are talking about, say, India having a plant-based diet are the people who are actually going to, so they bring in a lot of plant-based foods, a lot of packaged foods, which they say, this is what is best for the climate. So in the interest of climate change, all of you be malnourished. So that is their whole premise. That food which they are promoting, it is mainly soya based, it is mainly corn based or peas. That is their base. And to that, they add a whole lot of chemicals, a whole lot of additives, and trying to package it to us. And in fact, they were saying you should start early in the children. You should start promoting plant-based diets in the adolescents. So we need to challenge that, because the science, there is no enough science to justify that rationale. In fact, I think the focus in terms of climate has to be on the other polluters, which are the biggest polluters. And in terms of animal red meats in India, like for example in UP, they brought in cattle slaughter bans. People are not slaughtering the cattle. The cattle are roaming around, and those cattle are emitting a whole lot of methane. So if you're banning beef, then you should also ban milk. If you're banning beef in the interest of climate change, then you should also ban milk. But then there's a group that is not going to allow that to happen, because you're rearing cattle for milk, and then you're not slaughtering it, and those cattle are going to live for years, and they're going to be emitting a lot of methane. And methane, the way it's not like other fossil fuels. its life cycle is very different. So, of course, cattle and meats and poultry and fish have to be managed in a much more efficient way. There's no doubt about that. But the way they're being targeted, it's completely a corporate agenda. And I think we need to also critique that and challenge that.
Yes, ma'am. Actually, Naveen, do you have any question? You have raised the hand for some time. Naveen, are you there? You are muted.
Yes, thank you. So first of all, I would like, are you able to listen me properly?
Yes, Naveen, we can hear you.
Yeah. So first of all, I'm really very happy because the whole genesis you pointed out beautifully. It is the caste, it is class, it is politics in health. I think I'm in this sector almost 1 decade. I'm first time understanding things like in this dynamics. It's really very beautiful. So if I also did something on that aspect. Anyway, I think my thanks to all the organizers and my also thanks to the doctor beautifully capture the whole aspect of this. But if you analyze go into detail, then the health depends on food consumption. Food consumption depends on economy. Economy depends on sociology. Sociology depends on ideology. If we go into that detail, the whole thing, I'm really very happy, and definitely I have one, but that definitely I'll ask later. So this is absolutely my thanks to all, and I'll attend all the 5 meetings because the little bit hodgepodge is almost is going on. Whether you call the racism is the hell and casteism is the hell. It's unknown in India. Racism is health is almost is going up. So I'm very thankful. Definitely, I'll read. Thanks a lot once again.
Thank you.
It's a good one. Yeah, it's a good one. Yeah.
Thank you.
So I think we'll take one or two questions, ma'am. If anyone want, they can ask directly. Just raise your hand. We will call upon you.
There is a question about autoimmune disease and caste, and whether that's affected by nutritional tests, food options, and other living working conditions.
It is by Ita.
Yeah. Actually, I mean, autoimmune diseases have their own trajectory, what do you say? There are some markers and there's some genetic basis for autoimmune diseases, but there's also like environmental conditions. There are also other infections. So, for example, with COVID, and they're seeing some long COVID effects. They're seeing some long-term effects, and those could be due to autoimmune responses by the body. So definitely viral infections can cause either they can cause autoimmune conditions to flare up, or pre-existing conditions to flare up, or they can cause new manifestations. But even in terms of the COVID pandemic, there's been some research that says that people who have a poorer nutrition are more likely to have worse outcomes. Especially they were talking about vitamin D deficiency. So there is, so even if someone has an underlying, say, autoimmune disease, malnutrition can aggravate some of those symptoms. But whether it can cause, I'm not sure. So I'll probably have to do some a little more research on that. But definitely it can, make the symptoms worse.
Yes. So I think no other questions. So.
So I've shared some of those links in the chat, which I mentioned.
Yes, ma'am. Even others too also I have shared. So we will also share with the email with them. Just saying
Yeah.
both of them. Yeah.
Okay.
So, okay, ma'am. Oh, there is last question, ma'am. The intervention system, especially staff and infrastructure, need focused training for caste-based victims. So also there is a separate budgetary provisions. So can we look? So it's just like a maybe opinion, ma'am. So how you go about this, like training for
it's an opinion, but I also think that if we actually want to seriously address it, then we should start having much more representation in terms of decision making, whether it's in the healthcare system and whether it's the other social determinants of health. I think we are seeing that a very narrow caste group making decisions is not actually helping either the health outcomes or in terms of the nutritional outcomes. So we need much more representation, and we need more of evidence-based interventions. That's why I hesitate to call them policies, because policies necessarily have to be evidence-based, but the kind of decisions that are being made in our country are more, ideological or, caste-based decisions. So I'm not sure about, training people, which is what you're saying in the chat, because it's not like people are not aware. I think when it comes to issues around caste, I think representation matters. Whose voice gets foregrounded, whose decisions get foregrounded, that is important. But also, I think holding people accountable and saying, like, for example, with COVID, if the outcomes were bad, we need to say who made the decisions. What was the basis for the decisions? Was it based on evidence? Was it based on science? Was it based on experiences from other countries? Or did you just, randomly make a decision because of your, caste or class location? So, for example, with COVID, they shut down a lot of the very large tertiary public hospitals, and they converted it into secondary COVID facilities. And because of that, a lot of people, whether COVID or whether non-COVID patients, they had huge issues. TB patients, people with HIV, pregnant women, people with cancer who are accessing these public hospitals were not able to access it. And therefore, those non-COVID issues were huge. We are expecting a surge in drug-resistant tuberculosis or drug-resistant HIV, pregnancy-related mortality or morbidity. So we should start asking, why did you make these wrong decisions? Like, did you have any basis to shut down, say, public transport, to shut down public toilets, to shut down large public hospitals? So I don't think, I think people need to start asking questions, and that's why discussions like this are important, because then it takes all of these, things from the expert domain into the domain of people. Like, if people know that, this is nutrition, what we need is diverse foods, we need nutrient-dense foods, then they're able to counter. They're going to ask, why are you, in the midday meals, why is it so cereal-centric? Why is the PDS only giving rice? Why is the PDS not giving eggs? Why is it not giving us ghee? Why is it not giving us butter? Subsidize that and give it to us. Why are the cattle slaughter bans coming in? Why are eggs not being given in schools? So the questions have to come from the communities that are being denied what they traditionally know is good for them. We need to basically reaffirm that.
I just wanted to ask one question connected to what you mentioned about, we were talking about right now. So when it comes to the nutrition deficiency of children, there are not many things that the state is doing, but midday meal was one of the things that they launched with objective of improving nutrition and also improving school attendance. How effective do you think it has been across, since it was launched and so far, because that they have not been given eggs for so long, and there are only few states who are giving eggs now. So how effective midday meal has been, and what other interventions can be thought of for school children to improve their nutritional intake?
Then I'll need another 1 hour to talk about this.
We will have one more session on that, ma'am.
Yeah, no. So basically, see, the midday meals is a huge area, and in fact, the guidelines for the midday meals, and the reason why it was brought in was there was a whole, idea behind bringing in the midday meals. Of course, one is to address the malnutrition, because a lot of children are actually coming hungry to schools, but it's also to encourage children from different caste and class groups to eat together. It's also to encourage the cultural local foods. So if a child is used to eating certain foods, it's to also bring in those foods and make it a part of the midday meals. But over time, like now, across different states, the contract has been given to Akshaya Patra, which is, their whole ideology is, they're the sister concern of International Society for Krishna Consciousness, which is openly casteist. Like they talk about sattvic foods. They say that you shouldn't eat tamasic foods, and all the foods that marginalized communities eat has been labeled as tamasic, literally. It's, the onion, garlic, meats, eggs, all of those are being labeled as tamasic. And it is, if you see the kind of language that they use to describe the foods, they say it increases the lust, it increases criminal tendencies. So basically what you're saying is people who eat these foods, the traditional communities, are basically lustful, they're basically criminals, they're basically criminal minded because of the food they eat. But again, there's no scientific basis for that. And they bring in this ideology into the midday meals. So the food that they give is, again, very cereal heavy. They say that the food shouldn't have a lot of spices. It's not good for the children. So children, what foods they're eating at home, when they come to the schools, it's very bland, it's very homogeneous. It doesn't have the taste that they used to. So definitely children are consuming less. And this food, in terms of quality, it's very poor. It's very little nutrients in that food. So you basically have cereal, you have a very watery dal, or some very watery vegetables, and that's it. That's the food that the children get every day. So definitely the quality of the midday meal has to improve. The addition of egg makes a huge difference. Like one, say for a meal, if a child has to get about 12 to 20 grams of protein, egg gives almost 8 grams of that protein. It gives very good quality, highly absorbable. It's in fact considered as a reference protein. So you compare the other proteins of other foods to egg. It's just standard, but eggs are not, being in context is not kept in mind. So definitely there's a lot of scope to improve the quality of the midday meals. And because of this whole ideological imposition, even in terms of quality, the quantity, there's a lot of wastage of foods. Children are not able to eat these foods. And some people say these children are, poor, they're beggars. So, they should eat whatever is given to them. If they're really hungry, they should eat whatever is given to them. The idea of food as a charity and the idea of food as a right, I think it's important to draw those lines. Children have a right to food that they enjoy, to a full stomach, to satiety, feeling full, feeling, okay, I enjoyed the meal, to have a tasty meal. So Akshaya Patra, they say it's hygienic. Again, there's a very caste angle to it. Why is the food cooked in the school not considered hygienic? Why, if sometimes the mothers are the ones who come as a cook to the school, why is that considered as less hygienic than, say, Akshaya Patra? So, all those ideas of pure foods and, sattvic foods and, hygienic foods, they all come from a very caste based position, but not at all scientific, not at all nutritionally adequate, and definitely not tasty because the children don't eat it.
Yes, ma'am. So I think we can close now, ma'am. So it's time to say vote of thanks. So thank you so much, ma'am, for in spite of your busy schedule and personal and professional life, and in this night time. So thank you so much for coming here and talking and giving us an insightful, informative session and like even interactive also. So thank you so much. We got so many points, and we got so many points to take us. So, and then it's, I also thank all the participants, even though with your busy schedule, you came up, you were still here from 7 o'clock. So, and I, lastly but not least, but I thank Aditi and his team who are who are continuously planning, executing all the stuff from so many days. So it needs so much of our work and teamwork also. So thank you everyone for your valuable time.
I just want to say that I mean, I already appreciated for doing this, but I think it's very, very important the work that you're doing, and um, the it brings in it brings in change. These are the things that actually get people to start thinking, and you'll have made the effort, and you'll have formed the group. I think it's also, if you can form a Bahujan nutritionists and Bahujan doctors, that will be very good. So that should be the next step. Thank you so much.
Yeah, we will try to share some groups if we come across, and our recording will be on the YouTube channel, so you can have a look at it tomorrow probably. And Sylvia, thank you so much for this. I think Suresh has said most of it, but I also wanted to thank you for speaker suggestion and also helping us plan the session better. That was really helpful. And we look forward to having you more, because there's so many questions that I still have to ask and that everybody needs to find answers to. So we'll get in touch again.
Yeah, sure. Thank you. Bye-bye.
Bye.